And on the budget.
Yeah.
Yes.
Oh, you just confused. No, I didn't feel like I guess so. Okay. Super. Say no.
All right, we're going to get started. Good afternoon, everyone, and thank you for being here today for this third meeting of our provider price variation stakeholder discussion series. I really first want to just thank all of my agency advisory council members who are here today for participating in this stakeholder series. This has been an incredible opportunity to learn and to share perspectives over the course of these 6 hours, focused specifically on provider price variation. And I know have sparked so many conversations outside of these particular meetings, and that was really our intent and hope for holding these stakeholder series, was to continuously put the urgency that this commission feels around warranted provider price variation in Massachusetts, and bringing together a coalition, the coalition of healthcare stakeholders, providers, health plans, consumers, so many different perspectives around this table to really help to think critically about what are some real potential policy solutions that we should be advancing here in Massachusetts. I want to acknowledge and thank all of you who are watching and participating in this meeting via the internet, on YouTube. So thank you for your interest in this work as well. We are live webcasting this meeting, and so as a result, we'll ask and require everyone to please share your microphones with your friends and colleagues and neighbors around you, and we will try to keep the microphones going so that we can be heard on the live webcast. Before we get into today's agenda, I think it's worth, again, going around the room and just introducing ourselves so that everyone here in the room and participating remotely knows who's here. I'm very pleased by the tremendous attendance of our HPC commissioners here at this meeting today. I think you can see that this is an issue that the board has really taken as critically important. And so I will first ask my board chair, the HPC board chair, to introduce himself, and then we'll go around the circle. And please do use the microphone.
Thank you, David. I'm Stuart Altman. I have the pleasure of chairing the Health Policy Commission. And, I too want to indicate both thank yous to everyone who's here. And I clearly, it's indicative of how important the subject is. How to deal with this complicated subject is not easy. There are a variety of mechanisms to do it. And I like the way we've done it. And, that we're looking at demand issues, supply issues. Now we're going to talk about the state that's been involved in trying to do it in a more regulatory way, still using the forms of competitive things. So anyway, I'm glad to be here and I'm looking forward to the discussion.
Marty Cohen, member of the commission.
David Cutler, member of the commission.
Wendy Everett, Vice Chair of the Commission.
Lauren Peters, Administration and Finance. Alice Moore, Health and Human Services.
Megan Collins, Mass Nurses, sitting in for Julie Finkel, our Executive Director.
David Spackman, Lady Health. John Irwin with the Conference of Boston Teaching Hospitals.
Marcy Sindel, Adria's Health. Laura Pellegrini, the Massachusetts Association of Health Plans.
Hi, Tara Gregorio from Mass Senior Care.
Chris Hager, Beacon Health Options.
Floyd, Associated Industries in Massachusetts, and a member of the Health Policy.
Karen Rama from MHA.
Ryan Ross from Healthcare for All.
Chris Keeley with the Mass Business Roundtable.
I'm Monica Sani here for Assistant Secretary Dan Stein for myself.
Elizabeth Daly, 1199 for CIU.
David Brown, Stewart Healthcare.
Steve Walsh, Mass Council of Community Hospitals.
Greater Boston Interfaith Organization.
I am Mike Caljo, I'm Blue Cross Blue Shield of Massachusetts.
Sarah Sadownik, Health Policy Commission.
Amy Katzen, Health Policy Commission.
Tiffany Chipty, I work with the Health Policy Commission. Monroe Mills, Director of Policy for Market Components of the Health Policy Commission.
Josh Jarkstein, thanks for having me here, Associate Dean for Public Health Practice and Training at the Johns Hopkins Bloomberg School of Public Health.
Great, thank you. And I do want to recognize Dr. Sharfstein, who is with us today from Maryland to share his perspectives and has prepared a presentation for us and is generously willing to engage in the conversation with us around solutions and perspectives from another state. So really appreciate your time in being here. Also do want to recognize Tasneem, who was introduced earlier, is our one of our key expert partners in doing economic modeling and analysis. And so we'll be showing. And so when we get into some of the data, she's here to be able to help you answer some of those specific data questions. So for today's agenda, just to lay out where this is going, this third meeting, we really wanted to focus on policy options that have a common theme of around direct limits on price variation. That we'll be presenting today do, in many cases, envision a greater role for government in being able to either set guardrails, set targets, or in some cases to fully administer prices for healthcare services. We'll talk about the variation and some different models and options that may exist within that, and we'll be showing on the HPC side some new data and analysis presented for the first time today to really help put into place for you what some of those options may look like in a Massachusetts specific environment. I have a presentation from Dr. Josh Sharfstein, as mentioned, talking about the Maryland experience. And as is our case, we will have discussion and questions throughout the 2 hours. But I will keep us on track because I really want to make sure that we keep the last at least half an hour, maybe 40 minutes, for a discussion among this group about where do we go next. Because this is the third meeting that we had planned. This is the final meeting that we had currently planned. And I would love to get your perspective and feedback on these three meetings in general, and where as a community we can go to advance some of these ideas. So with that as a rough agenda, I'm going to just dive in and start to frame up today's meeting. This first slide, slide number 3, summarizes our key findings and work from before. This is well known to everyone here. Specifically highlights the 4th and 5th bullets here in terms of our work in saying and trying to understand that there is both potential warranted variation and as well as unwarranted variation. And what are those factors as a community and as a state do think should rightly be paid more for and rewarded for when it comes to higher quality care or more acute patients, or potentially a teaching mission or providing more specialized services. And so we'll have a conversation today about how other states and other countries and other payment systems have thought about making adjustments on prices based on specific value-based factors. Also would highlight the fifth bullet here in terms of looking at what other states have done. That will be a key part of our discussion today. As a brief recap from the 3 meetings, I think for those of you who have attended, the first 2 meetings were really focused on demand side, incentives and policy options, as well as supply side. And in many cases, what we were really talking about was how can we put in place policies to make the market work better, to make the market really reward high-value providers, or to use our payment system to transition away from service spending as part of a broader view of using global budgets and total medical expenses as really a goal. This third meeting is a little bit different, and here we're going to be talking about interventions that would envision a greater role for government and what that may look like. So today we are talking about direct limits on price variation that may provide a more direct and targeted approach to addressing unwarranted variation. We're going to talk about 3 specific options. We're going to talk about the concept of rate banding, a concept of differential growth rates for different providers depending on where they have begun or where they stand in terms of their efficiency, their prices, or where their global budgets are set. And then finally, we'll talk about limiting price variation either in a fee-for-service basis or on a global budget basis to value-based factors that we have identified that provide benefit and value to the Commonwealth and to patients. Some different payment systems, including Maryland and Medicaid, there are ways to implement these ideas that it may be with some of the other ideas we talked about in previous meetings, and that the role of government need not be set. One can envision many of these options that does not require a fully administered rate-setting process. That is certainly one option, but the role and scope of the government's role here is something that is up for discussion and can through these types of policies. And I think we have tried to put here a number of the different goals that have come up so far in terms of being able to control spending over time, to have a marketplace that works better. But as has been noted, we're also interested in the financial stability of low-cost providers and ensuring that they have a future. The challenges with some of these direct limit policies are revolve around the resources necessary to do this, the complexity of trying to define appropriate levels of variation, and then finally, of course, guarding against the potential for unintended consequences with any of these ideas. So with that as just a pure framing for today's conversation and some of the key questions that we're hoping to get perspectives on, I think we're going to dive into the work that we've done, and we'll show you the 3 options as laid out: rate banding, differential growth rates, and direct limits on appropriate factors. So unless there's some immediate comments from the advisory council, seeing none, I think we'll dive right into our content. So I'm going to turn it over to Kate now.
Great, thank you, David. Great, so for the next few slides, as David said, I'm going to walk you through some of the examples of how some of these systems might work. And so this first slide shows the concept of rate banding. And by rate banding, we mean any type of policy that really prohibits prices from varying more than a specified amount. So we put up two different models of how this would work, but I do want to note there are different ways that such a policy could be implemented. This first image on the left shows an example of a rate banding approach. People would be committed to receive rates that are
We've had several changes in our board members, which worked on this, but our board has endorsed in 2020 as something that we think could bring significant savings to employers and consumers and actually bring up the bottom providers in a meaningful way. So we have a long history with 80/20, as you know. It was first proposed by Mark Copley's team, and it's something that we took serious look at and just wrapped our heads around. But we think that would give us the biggest bang for the buck and be the easiest to implement and have immediate results.
And maybe just explain really quickly the 80/20 for that.
Okay, so that would be taking, but basically plans looking at their contracts and taking those contracts that are above the 80th percentile and bringing them down to the 80th percentile and then bringing up the bottom to the 20th percentile. And the way MLR standards and rebates work, et cetera, money would be returned to employers and consumers as well, because bringing down at the top would be significant savings.
You would just make it down 20% rather than say this.
So taking the top down to the 80th percentile and taking,
Which means a much slower.
yeah, I mean, I
Isn't
think
it
we're,
percentile median? In other words, if you're using a percentile, then I think you're taking median as opposed to averages.
Yeah, no, I think the media makes a lot of sense. So, but I mean, yours is a very minimal rate.
and I want to say, I think that we are flexible on where we landed on the number. That was the initial number presented by the Attorney General's team under Martin Copley, so that's what we worked with. And at one point, we had modeled the savings. We haven't done that recently. But I think that kind of construct, I guess that kind of construct, we think will
Do
save
it
us.
by cohort, the way the second chart.
We did not, and that's, I had never really thought about that. But again, I think the key is that MAP would be willing to engage with the Health Policy Commission, the AG's office chair. It's kind of,
Yes.
So I think Laura mentioned, one of this type of approach is that when we thought about what is the outcomes we're trying to achieve, it would provide more financial resources for the lower price institutions, and depending on where you set that rate band, may result in some significant savings to the system overall. Let's
Keep going.
Great, so the conversation has obviously highlighted one of the big decisions that would be part of this type of approach is how that band is set, whether it's mean, median, percentiles, what the numbers are. Some of the other kind of considerations that we noted for this included whether or not it would apply to all hospitals or whether there would be specific exclusions of some of our larger specialty hospitals, for example. Obviously, there's also a question of whether or not this would just be applied to hospitals. A number of the approaches that we've seen have been applied only to hospitals, but we could consider an approach that also did this for physician groups, for example. One of the big issues would be on what time scale. Would this be all at once, or would it be somewhat staged out over time?
Marcy, did you?
Yeah, just a comment that we're also going to have to think, if, in this kind of approach, if you start looking at it mathematically, and you start to cut off the tails, you drive everybody to the median. And so doing this forever and ever is also viable.
You're going to reach a steady state really quickly.
Can you advance to the next slide? All right, well, we can go off of the paper copies that we have in front of us.
So another policy approach is what we are calling differential rate increases. And so the concept is pretty simple. Providers, be it hospitals, physician groups, or other types of providers, would be permitted to different levels of rate increases based on their initial price. So the first slide that you'll see in your deck shows, for an exemplar payer, how rates converge over time if the lowest price providers were permitted relatively large increases, while moderately priced providers were allowed moderate price increases, and the highest priced providers increases at all for some period of time. I do want to note that the HPC modeled how long it would take to reduce price variation in this in the current market using this type of approach. And we found, as we published in January, that due to the extent of variation that currently exists in the market, even if that lowest price group of providers were permitted 3.6% annual increases, it would take almost 20 years at the current price levels for them to reach even the price level of the 75th percentile today. Obviously, the timeline for convergence is variable, and depending on how we weighed different considerations, we could set the rates of growth differently. Obviously, there could be a scenario where the highest price providers were permitted to grow, but at a lower rate of increase, while the lower price providers were also getting a higher rate. That might just extend the time frame there. Finally, I'll note also that I've been speaking about it with regard to price, but the same type of approach could also work with regard to spending levels. And so you could create a differential growth rate approach based on spending levels and allow increases to local budgets based on where the starting point was as well. So moving ahead to slide 10, the third area we really want to discuss is the concept of limiting variation in the market to certain acceptable factors. So I want to note up top, just going to a lot of David's points at the beginning, that this could be implemented in a range of ways. Everything from, say, a full rate setting system, lighter touch, where market negotiations would occur, but within certain guardrails. So as an initial stand of what might constitute acceptable factors for variation, examine a wide range of different pricing systems across the market, both here in the United States as well as internationally. And we found that there's actually a pretty common nexus of factors that most systems identify as acceptable reasons for prices to vary, for hospital prices specifically to vary. So as you'll see on the chart on slide 10, clinical complexity, geography, teaching, high-cost outliers, and for those systems that are not single-payer or all-payer systems, payer mix or uncompensated care really exist across all of the systems that we looked at. There are a number of other adjustments that are unique to some of these systems, and we've highlighted those in the last column. As an initial thing, we wanted to also just zoom in a little bit on Medicare, since that's obviously a major payer with which I know many of you are very aware, and focus on some of the adjustment amounts specifically in that system.
I think before we jump to the adjustments on Medicare, I think it's worth spending just a minute on this previous slide, and whether comments now or comments as we go through this, I think this is a really critical question for this group to think about, is if there is an approach that limits variation to acceptable factors, what are those acceptable factors that, as a community, we do want to reward and pay for? We put these here as examples that we had found that were common among different payment systems, but one can think about other adjustments and would note, certainly in some of the single-payer international countries where they have made adjustments within the payment system for research and innovation. That is not something that is typically included in these variations, but it's something maybe worth a conversation here about. So I want to pause and get people's feel around these 5 criteria as kind of acceptable factors. What are other things that we should be thinking about and looking at? And just pause here before we show you what Medicare looks like.
So obviously we like the fact that teaching is in there. And HPC, I think you looked at 16 factors in the original report. So there are, and I think Dr. Altman mentioned that at our first meeting, there's reasons for price variation, I think, that we all think are good reasons: physician education, specialized services, level 1 trauma, and all that. So I think that our experience with Medicare is they almost use the teaching factor or the IME factor as a proxy for other things. So included in the IME factor in Medicaid's mind, Medicare's mind, is maybe research or that standby capacity or the specialized services. So I think that when we're talking about this, I think we have to, unless we're going along with what Medicare uses as a proxy, I think it would be helpful to, a lot of these are the things that we consider as reasonable or acceptable reasons for variation are in the other category of research and innovation and standby capacity. So I think that just saying teaching is not enough at this point. I think we have to split out the other, put it all back into teaching. But I think at this point we need to differentiate between those two.
It's a great point, and we'll show you when we had done our regression analysis. I think we had both split up teaching status and shared tertiary services to try to get some of that. But Paul,
Question for Dr. Sharpsky. Unless it's going to come up later. One of the things we talked about, for example, the Partners Healthcare, the October submission, said that one of the things they think they ought to be subsidized for, in addition to teaching and research, was behavioral health. And we talked a little bit last time about specialized burn unit kinds of services that they have standby capacities. In Maryland, either of those things explicitly, in addition to the other factors here, and as well as research. I assume research is not part of what you explicitly subsidize in your global budgeted rate. I say subsidize, I should say a buildup of a rate that includes that as a factor. I think that's a better way to describe it.
Maybe easier for me to directly address that as I'm going through, because it's a kind of more complicated answer, but the short answer is yes. Yeah, like very specialized services get extra consideration. How that's done,
I bring this up only because in the last slide, physicians were mentioned. So in the case of physician prices, you would need a difference, things like unbillable infrastructure that supports primary care, you hold expense, whether or not your physician subsidies from somewhere else in the health system and your quality.
I have to say something. Much as I think they're all good things, those are, you really want to, Dr. Sharpsky will talk about it, those kind of issues, which are very important, so I don't want to minimize them, shouldn't be thought of in a price issue. They should be thought of and think about total medical expenditures and stuff like that. That's why he's moving, or Maryland's moving to that bigger system.
Yeah, I think if the whole system goes to value, I agree. If the hospitals are still being measured on price and the physician groups are being measured on total medical expense, since in many of our systems that's largely where the risk is, then you have to consider how, for example, freestanding physician groups, which don't benefit from these subsidies from the health systems, are going to fare. And in fact, some of the price is due to how it's a compensation, in fact, for how they do it. So it's different. The difficulty is applying all of these things when you have different structures to organizations. Right. Even within the hospital system, there's a big difference between a freestanding community hospital that's largely living on its own bottom and a community hospital that has the ability to receive capital from larger academic medical centers. So it'll be interesting to hear how Maryland deals with those differences, but I think we largely disregard the fact that capital can be moved around within the system when you only act on part of the system you find. Also take
So, looking at this list, I appreciate that it's a helpful analog or set of analogs. I actually think we would do well to build up discussion separately of what we deem as a community are the acceptable and unacceptable factors that are rooted in many ways here. Very detailed and complicated question. And we've had discussions about this. I think we would want to get stakeholders in the community at large together to have that discussion rather than just adopt in a rote way another model where in some cases there is already that continues to exist. Medicare, for example, it's still has a level of variation that in many cases is more than, for example, what the ballot initiative envisions when you total it all up. The second point, which I just want to put out there and have people start to think about, and it's a difficult question, is we could come up with a brilliant system, but we will also need to decide how to create a system that is not vulnerable to political gamesmanship every year through a series of exemption requests or legislative amendments or regulatory gamesmanship. And I don't have an answer to that, but I think as we discuss this, we should also discuss the concept of creating a black box, a contained system, so that the best laid plans go awry over time.
Let me ask you this question, just for the sake of the discussion, not do it in a slightly antagonistic, but not really meaning that way. You are now the regulator, because that's what you do. And so what the question becomes is whether some other regulator could do a better job than you're doing. I mean, not you personally.
Yeah,
but
I think it depends on the guardrails they do put in place.
because
I-
when you say all these complexities.
So
that
one
means-
complexity is, I would not envision a system, for example, being beneficial that codifies these standards in statute. And therefore the legislature is the guardian at the gate, and therefore every year it comes through a series of debates that in many ways becomes very akin to what Congress engaged in around federal base closing and delayed on that. There is a mechanism that I think could be helpful, particularly if it's market-based with guardrails, that one could see as a particularly well-envisioned concept. And I guess that's my answer to it.
No, thank you, that's a very good answer, thank you very much.
Any other comments and thoughts? And I don't think we're going to have consensus on the list of acceptable factors today, but did want to at least tee this up to David.
Just a quick comment for consideration or maybe caution. Medicare is built up a very archaic fee-for-service chassis, and within Medicare, not only do we have variation, but we also don't have a good way to measure total cost of care for the providers, including hospitals, physicians, and others. But also keep in mind that even at Medicare, there are 11 different payment teams that don't meet, don't speak, and they're very siloed. And so how we get to the total cost of care and whatever structure we think about is, I would urge us to focus on.
That's a great point, and I think actually a nice segue to the next couple of slides where we do specifically look at Medicare, the variation that exists in fee-for-service Medicare. And I think the purpose of these is really to be illustrative and to help surface those types of things where we can look at something else and say, yeah, this may make some sense, but we need to think of it in context of local budgets for this something specific about Massachusetts environment. Thank you, David. So, Kate.
Great. So, so here we wanted, again, just to show some examples from the Medicare system. If there were a policy that the state wanted to consider that was in this acceptable factors space, adjustment amounts for those factors. And so these are the examples of the adjustment amounts currently for the FY16 acute inpatient hospitals under Medicare. So here, as you see, there is a geographic adjustment. However, it's relatively narrow in Massachusetts at this time. It's around 3%. And for teaching status, that is a maximum of around 40% that we saw based on our calculations in the Massachusetts market. The adjustment for disproportionate share of low-income patients, again, based on our calculations, the maximum in Massachusetts is expected to be around 11%. And then, of course, there are additional rate adjustments, such as the rural adjustment, but relatively few hospitals qualify for those in Massachusetts. And for illustrative purposes, again, we also did this for physician services. And similarly there, the Medicare adjustment amounts are pretty narrow. So in Massachusetts, Medicare only pays differently for practice expenses. And that is really only a 9% difference. Yes. And for facility. Yes. Yes, this is on the professional side. And so to give an example, for a 15-minute evaluation and management visit, Medicare really only pays essentially two rates in Massachusetts: $79 if you're in Metro Boston, $75 if you're anywhere else in the state. That's about a 5% difference. In comparison, in 2013, Blue Cross paid 139 at the 90th percentile, or 66 at the 10th percentile. So that's more than 200% difference in the commercial space, same percent.
And for these purposes, not picking on Blue Cross Blue Shield, this is a consistent trend across the major commercial players.
Absolutely.
Great question about this one. The outline, the folks in Medicare, we've seen in some ways variation that's even greater, especially at the higher end. That's Medicare outlier payments that's driving that.
Oh, on this slide.
That's one.
Yes, so this next slide does show that Medicare prices vary, and so this is only for the IPPS hospital. So I'll note from the get-go that the hospitals that are paid under the system are excluded from this analysis, and the several other ones have outlier payments included. So here I want to give credit to our friends at CHIA for doing this analysis at our request. So they actually applied the relative price methodology, which is built back from revenue. So it's all funds received through fee-for-service Medicare by these hospitals under any of those.
But it's a treat case, it's real outliers. It's not outlier, it's a payment structure.
It's not like, you know, the plan manufacturers were helping hospitals figure out how to get outlier payment for their procedure. It's not like that. It's geographic.
Surely should know we get those outlier payments. Small hospitals.
Yes, so these are actually a range of different things included. So certainly geographically isolated hospitals do tend to have higher rates added on. There's also relatively high rates for DISH and teaching, and so you see that actually some of the highest priced hospitals on traditional Medicare are our teaching hospitals that also have DISH status, which a few later slides is kind of the opposite of what you see in the commercial market. And so really quickly, as I said, this is showing relative prices for traditional Medicare versus the three major commercial payers. I do want to note, as I said, these are relative to an average price, and so this does not mean that the prices in these three networks are the same. But as you see here, prices do vary, even in an administered system like Medicare. Obviously, it is defined certain factors upon which those prices can vary. Another thing to note is that when you do have an administered system like Medicare that has defined those acceptable factors for prices to vary, you see that most of the hospitals, however, are kind of in the middle. There are a few on the edges, but most of them are in the middle, which is different from what you see in the commercial market. And so to show that a different way, this slide shows hospitals' volume and revenue broken down by kind of relative price groupings. So in the Medicare system, where, as I said, prices do vary, but they're based on certain acceptable factors, the vast majority of prices receive, vast majority of providers receive prices in the middle. So here in the leftmost bar, you see that more than 3/4 of hospitals in Medicare receive inpatient hospital prices that are within 20% of the mean. Additionally, when you look at the concentration of volume in the middle bar and the concentration of this bar, you see the volume and payments are also in the middle of the distribution. So, and then I think also really informative is looking at the very top section. So in Medicare, only 9% of the hospitals had relative prices more than 20% above the mean, and those hospitals accounted for 9.9% of the volume and 14.8% of the revenue. To show you a comparison from a commercial payer, and again, not trying to pick on any specific commercial payers, but Showing Tufts as an example, but it's consistent across all of the major payers. Here, you see that fewer providers have prices near the middle. So in the Tufts network, fewer than half have prices within 20% of the need. And you see a very substantial concentration of both volume and revenue among the highest priced providers. So remember that for Medicare, only 9% of hospitals had relative prices more than 20% above the mean. And those hospitals had 9.9% of the volume, percent of the revenue. Here, obviously, you see that the 23.8% of hospitals that have the prices in that kind of above 20%, above the average, they account for 47.3% of the volume and 63.5% of the revenue. And again, across the three major payers. We also see that where prices are allowed to vary based on certain acceptable factors, the price levels have very little relationship with the price levels in the commercial system. So there's essentially no correlation. And as I noted before, among some hospitals, this difference is really quite marked. So, for example, among all of the non-hospital specialty hospitals in the state, it's actually Cambridge Health Alliance that has the highest relative price for Medicare. But its prices in the commercial space tend to be in the bottom quartile. AMC's Boston Medical Center has the highest Medicare relative price, whereas among the AMCs in the commercial business, they have the lowest relative price. So transitioning a bit to Massachusetts, what would it look like here? So this is just a reminder. This is a slide that we showed back at our January board meeting when we published our report on provider price variation. And this is really summarizing the regression analysis that we did in partnership with Esme Chipley and her team at Analysis Group. And so when we looked at the factors that underlie differences in commercial hospital prices, we found that variation is not generally explained by differences in quality or geographic differences in wages, or factors structure with less competition and larger system size, predicted higher prices. And so to look at that in more depth, we conducted an additional analysis of inpatient hospital prices where we held certain factors related to competition and system size constant for all prices and predicted how that would change relative prices. So we did that for the three major payers. Here you see an example, again, only for costs, showing that essentially if you backed out some of these market structure variables, everybody faced a higher level of competition, was a similar size. You'd see significantly less price variation in the market. That's at least what our model would predict. So that's the orange line here, showing that the majority of hospitals would now have prices. You see there's a big spike in the 0.8 to 1 range.
So can you tell us more about what you mean by measured factors in terms of price and how it's trended? Is it applied to current contracts? And you applying it to how are you adopting measures for the purpose of that slide?
Sure. So I'll do a little bit of an answer, but then also turn it over to Kathleen if she wants to add. So this is actually the regression analysis that we published in our January report. So at a high level, I'll note that there's a whole technical appendix spelling this all out in great detail. We did look at the inpatient relative prices. And so this is based on relative price data, I believe from 2013, apologies. And then we looked at a number of different factors that contribute to that. And so specifically, we looked at the size of the system, the number of competitors that they have, and the type of competitors they have if they're competing with an AMC. Those are the factors that we actually backed out of this model to generate the orange line. And then we left the other factors in there. And so we left quality measures, income in the service area as a proxy for local wage differences, the hospital type. So we allowed price variation based on whether a hospital was an AMC or a teaching hospital or a community hospital. And we left in the factor for the share of services that are tertiary. So if the hospital is providing tertiary services.
So the way things are now is the navy blue line.
That is correct. So the current actual relative prices is the navy blue line.
Is it fair to say that apply either the relative prices are all measured assuming heightened competition, that the right tail, while slightly reduced, it still exists in a significant way?
That's correct. And so there are some acceptable reasons for prices to vary.
Did the hospitals change them? In other words, what I'm trying to get at is go through this machination once for the right tail now, still going to be significantly within the right tail and at the relative rates above everybody else.
That's not quite true. If you look at
There's some dampening of it.
no, this is substantial.
Yeah, help me understand.
If you look at that dark blue line,
Right.
and compare it to the orange,
I see area underneath.
essentially it hits zero. It pops around significantly.
Gotcha.
No, I think it's, I haven't even seen the slide myself. It's a very interesting slide, and it's the reality. I think you pointed it out too. Some form of competitive pricing, even with variation, you're going to have much more clustering around mean medians, and you're going to get rid of it. I mean, that's the nature of this exercise, because your question is a very good one. If at the end of the day it's all the same thing, what do we do? And the answer is this does. Whether you like it or not, that's another question.
And let me just add that the actual identities of the hospitals are different in the simulation. So, you asked if the same the sort of, if you will, the relative ranking of the hospitals is the same.
Right.
Yeah, the identities of who's where could change. Might have characteristics that suggest that its current prices are entirely driven by competition, for example, geographic isolation, whereas other hospitals might be facing competition but might not be earning the same levels for the positive factors, and so those hospitals might profile.
To me, in the sense of equity, that's unfair. I mean, and if you end up, you tail for factors of evaluating as opposed to strictly, let's just say, negotiating leverage. You want to react to that?
Well, I mean, I think that's exactly the point that we're trying to make, is that when you have a system that defines certain factors upon which prices can vary, there is still variation that exists, as we saw on the chart laying out you do still see relative price variation in administered systems, but the factors upon which they define prices to vary result in a very different ordering of the providers. And so, as you recall from this slide, it has almost no correlation somewhere. Market leverage is a major factor in negotiations.
So one analysis that I think would be helpful for the group of stakeholders overall to see over time would be a revenue impact analysis on a hospital basis, because this has theoretical appeal. But when we cut back to the score and Z for a hospital, I think that's where a lot of the rubber will meet the road. And I'm saying that not as anything more than that should be one discussion point among many in this whole discussion.
You took the word, Fred. Thank you so much for bringing that up. I haven't talked to the staff, so this is, as someone who has been a regulator in my life several times, you couldn't be more right. So what I would like to see discussed in that is going back to the 80-20 rule. I think is this idea of talking about going down to the 20th and taking an individual hospital or a group of hospitals and moving them way down. Space. You would destroy institutions overnight, even if they were bad people and slovenly and you didn't like them. The reality is that we're not going to do that. So, and that's when you look at how every regulatory structure ultimately comes about, whether it's Medicare or Maryland or all the variations in other countries, they never do it that way. They do it slowly, and they don't, unless you want to destroy institutions. And unfortunately, some of our best institutions are at the top. We don't want to destroy them. So, two things that I would say. First of all, and as I said, I really feel bad about this. I think you want to focus on price variation in and of itself, and then decide how much money you're going to save in the system independently of that. You don't use price variation as a way to save money. It ought to be dealt with in and of itself, not as a saving mechanism. Saving mechanism should be in deciding how much money you want to have in the system and should be independent of that. Second, I totally agree with you. I think you ought to be realistic and talk. And the reason why I hadn't heard that thing, but the reason why the 80-20 rule, to me, sounds attractive is you're not going from 0 to 20, you're going from 100 to 80, and you're doing it slowly. The impact on an institution, while over time is not going to be trivial, it is not destroying an institution size what not to be, unless some of you want to destroy institutions in and of themselves. It's to sort of get the market into a better shape, to improve some of the things, take some of them down. So, I mean, if I were remodeling this thing, I would do it revenue neutral, slow, not, we can decide how quickly we want to do it. But to talk about going down to the 20th percentile from a huge gap, you would actually destroy institutions. And unless that's what you want to do, I don't, be careful.
Steve?
No, Commissioner, I generally agree with most everything you say. I will just say that the status quo is destroying institutions.
I agree.
It's destroying all the institutions at the bottom, so you should not be so concerned. Just with my little bit in that I would not do hospital A, hospital B. Let's leave it blind. And slide. Because if I'm reading this right, and this maybe is a true-false question, what this says, true or false, if you take market power out of a negotiation with Blue Cross and Blue Shield and leave everything else exactly as it is, every hospital, most hospitals, 70% of hospitals are within this. True or false? Is that true? I mean, am I reading? I just want to just lay the person's trick. I'm reading that slide.
That's how we would read it.
Every other, so I don't know who the hospitals are because the intent wouldn't be to have any proper names on the table whatsoever. It would be to do that exercise, change it in some way, and even do it over 10 years if we're concerned about hurting anyone. And then, like a need blind admission process, then put the names back on the paper so that nobody is protecting their particular interest. Community hospitals included, because there are some higher paid by relative place in hospitals. I think it's the fairer way to go. I endorse your idea. Let's take market power out, do it over a glide path of 10 years, and at the end of 10 years, it'll be a lot sooner than that. Everybody will be within 20% of each other.
The only other comment I'll add to Steve is we can't do this blind without including Medicaid and Medicare with some type of weighted average payer rate, right? It addresses probably your revenue comment, and second, it also balances out the slide in terms of impact. But I agree with what Steve said. Okay? The last comment I'll make also is I'd love to see the same exercise for physician groups.
I guess I would say the following. If a stakeholder group or the state doesn't estimate revenue impact, you're going to be subject to third-party estimates of that revenue impact. And I would rather go into this discussion with eyes wide open rather than not, because that battle will be joined at a certain point. I'm not suggesting that it's overwhelming. It has a preponderance of an impact, but it's one set of analyses that, frankly, I would have confidence in the state looking at as an example rather than a third party.
Sorry, dude. I just aren't we a stakeholder group? I think we are the stakeholder group. on the third of a series of 3 meetings. There's been another stakeholder group, Mass Hospital Association, had a number of meetings. They've come up with some other ideas. And the stakeholders have met, and I trust the judgment of our very talented legislators to be able to take the information that we have compiled and be able to do something that makes sense for the market.
So I'm going to keep us moving, and I think we'll come back at the end to kind of where do we go next with this. So I think we want to get to Dr. Sharfstein here, so we're going to skip a few slides and just tee up very quickly the price setting system of the past, and then really kind of create a foundation for Josh to talk to us about how they've evolved that system, what the impact of that system has been in creating what he would say is a more effective and efficient system focused on total medical expenditure. So, Amy, if you want to just quickly talk to us about Maryland's approach before 2014, and then we're going to turn to Josh.
Great, thank you all so much. So just very briefly to go through, and Dr. Sharfstein, feel free to jump in at any time. Before 2014, the state of Maryland operated off of a system as briefly described on the slide. So we're talking about cost-based unit prices, so very much a fee-for-service situation, adjusted where those cost-based prices seemed excessive back in the late 1970s, and then overlaid on top of that a per-case charge limit, so that, which is similar to the way we think about a DRG, and also further layered on top of that a volume adjustment so that we're not incentivizing infinite numbers of cases. And then all of that was adjusted annually for inflation and other health system changes, for example, updates based on new technology and other factors. And then, in addition, it's a very complicated system, there was also annual updates based on reasonableness of those per case charges. So reasonableness assessments took into account the factors that you see listed on the slide, and that is largely how that was done. So what you see is a efficiency assessment accounting for these factors. So someone is in charge that's inefficient because they have teaching costs, because that's not an efficiency. And then rates, if the charges are too high at that point, there would be an adjustment to unit rates. So that was the basic structure. And we can operate this thing. Yes. What we see is that this system not only did a lot of work to hold those per case charges to a reasonable level, but also yielded a lot of stability for the hospitals in that system. So notably, Maryland hospitals were doing quite well financially. There was not this the rate setting system was not creating hardship, is the message. And that's true across the system, and also including for Johns Hopkins, which you know, they have been teaching research, and they were doing that mission. So with that, very happy to transition to Dr. Sharfstein, who can say a lot more and also bring us up to speed with the new global revenue system, which is designed to build on the system. This system is kind of the baseline to encourage hospitals to care for a patient population and not have volume increases.
Great, thank you very much. I apologize in advance for the pun on my slide here. And then I would also say I feel a little bit like the red meat has been tossed out, and now we're going backwards to the appetizer, and the appetizer may be broccoli. So we'll see what people think. That proposed to me here, and maybe I'll jump in by giving a little bit of background, picking up, talking about the new system, talking about price variation explicitly in Maryland, and then circling back and answering the 3 questions. So this all started in the late 1970s, sometime almost equidistant between when I was really trained in my department. That's when rate setting started in Maryland. And a quasi-public agency called the Health Services Cost Review Commission. It's appointed by, members are appointed by the governor, approved by the Senate. They set inpatient and outpatient hospital rates for all public and private payers. The rates were based on a range of factors that you heard about, The way I like to talk about it is that each hospital essentially got a rate card. Every payer paid off the rate card. And I included Medicare, included Medicaid, included all the private insurers paying off that rate card. In other words, Medicare pays Medicare rates in 49 states in the District of Columbia, and they pay Maryland rates in Maryland. Medicaid pays 70% of zone charges, depending on the state. In Maryland, it's essentially 100%. And I say essentially, it means there's always a little fine print, but basically, all payers are paying the same amount off a rate card. Now, one hospital's rate card, though, wasn't necessarily the same as other hospitals' rate card. That's what everyone paid. And so this eliminated cost shifting between payers. It allowed for uncompensated care costs for pool. Basically, there's a 6% charge on every single hospital bill for inpatient and outpatient care. That money goes into a pool. It goes back out to the hospitals to proportion to the care that they provided. It's one reason there really no public hospitals in Maryland, but uncompensated care was paid for at every hospital where it happened. For a whole interesting range of creative incentives. With respect to medical education, I'll just mention, is built into the rates of the hospitals that provide teaching, and so it was all payers paid for it. Most places, Medicare pays basically all of it. In Maryland, all payers paid those rates. So, you know, if you think about it, it was a bonus. It was helpful for Medicare and Medicaid to participate. It brought in additional revenue from Medicare and Medicaid. But they did that with some conditions. So there are two conditions that were set. So Medicare gets to pay Maryland rates. Maryland sets the rates, but there's two conditions. One is that the rates have to be the same for all payers. So the commission couldn't get together and go, we got an idea, let's double the rate for Medicare. Then Medicare would say, deal's off, you're back on IPPS. Nor could they say like, maybe we should add a factor for anyone over 85, twofold. That wouldn't fly. They would drop out on the point. The second thing is the rate of growth of prices per admission had to be slower in Maryland than nationally. So Maryland prices had to grow slower. So think of two curves: Maryland price growth per admission and U.S. price growth per admission in the Medicare program. Maryland cumulatively had to stay below the U.S. And the distance between the Maryland curve and the U.S. curve was known as the waiver cushion. Okay, waiver cushion. So I'm graphing here the waiver cushion. That's what this graph is. Now, when the waiver cushion was like 9% in 2000, and this is just since 2000, okay about the system, right? Because they don't want to lose the system, so they've got 9%. Then it went all the way up to 17%. People are feeling pretty good about the system at that point. Everyone gets a new lobby. I'm just kidding. That's a joke. I know we're being webcast. Okay. So, basically there's room to do capital investments. There's all kinds of things. Then it goes down at one point in 2008 to like 7%, and people were really, really anxious because they didn't want it to go lower. Because what happens if those lines cross and the waiver cushion is cumulative? So what if it becomes negative? First, we started a transition period back to IPPS, and second, Maryland pays back the area under the curve. That adds up, right? So nobody wanted that to happen. So maybe 200 people in the state of Maryland knew what the term waiver cushion was, but that number was incredibly important, and we found it out 15 months after the fact. Okay, so you didn't know when you got the number whether it was going up or going down. So people were, everybody wanted to make sure, and people generally said about 10% where they wanted it to be, about the right one. So they got it. They did some different things. Different things happened nationally. This was a comparison. Then you'll see in like right at the beginning of 2011 the dramatic dive down. That's when I started as health secretary of the city. Okay, and it went down to 4.46%, and so it's like panic. Okay, people were very anxious because there's so much of the system depended on this, and it was really a problem. As you can see, when you found out 4%, you didn't know whether the lines had already crossed in the last 15 months. So it particularly caused a lot of stress. And so the state had to figure out what to do, and when we looked at it, we thought about what is the purpose of care generally. Okay, so bigger picture. This is the appetizer part, taking a step back from the main course. Of course, we want to control costs. We also want high quality, but we also want healthy people. We want, people healthy in Maryland. We want the state to improve in health. So I was responsible for public health in the state, just like I had been in the city. So in thinking about that, we had a very interesting model to look at, which was called TPR. It started under the old basic agreement, where the rate setting system made a deal with 10 rural hospitals voluntarily. They wanted the deal. And the deal was, we'll give you your budget in advance. It doesn't matter how many admissions you have. It doesn't matter how many MRIs you do. You will get that budget, again, essentially. We hope that you use it to reduce preventable illness. And so it was much more aligned with population health and the health of their communities than a fee-for-service system. And in fact, we saw substantially reduced readmissions, preventable admissions, and all admissions, in fact, compared to the hospitals that were not on that. Those hospitals actually did quite well financially. And so there was a period of time where I had reporters calling me about certain exchange. I was very the situation up here in Massachusetts around that time too. And I would try to get them to change the topic. And I would try to get them to write a story about total patient revenue hospitals, because I visited one in Western Maryland. And I walked into this hospital that had been built 8 years before, and there's this cavernous lobby, and it was completely empty. And I walked back out, like, something's totally wrong. I was completely lost. Finally, I figured out that it's just the hospital was terrible. Came bounding up to me with a big smile on his face, and I thought, if you weren't on a global budget, you'd probably be, on monster.com at your desk, right? Because it's like very unusual. And he said, this is just amazing. And he took me to the ER. He said, we have a team that visits every patient in the ER to see what they need so that they don't have to come back. When we send someone to a nursing home, we send a nurse out twice to double check with the transition of care. We basically have a culture change where we've trained every employee here, and the basic theme of it is we hope to never see you again. Okay, so around this time, my brother-in-law got married in Miami in July. We flew the whole group in from Norway. It was like 110 degrees. We're driving around Miami. So many billboards in Miami are like only 2-minute wait in our ER, right? And then this was around the time where there were scandals where half the patients, if you didn't admit half the patients, you got fired as an ER doctor. And there was one billboard, which I wish I had a slide of, which said, like, we're the only ER in South Florida that has a sunburn. And so it's like, they really, is that really good for the health of the community? Meanwhile, here in Allegheny County, they were saying, we want to, we hope to never see you again. And so I have a slide here that, like, our former governor, Martin O'Malley, used to say, we have to start thinking about hospitals differently than hotels. Whole slogans for hotels that could be slogans for hospitals that are advertising. Just, please come in.
Is the TPR based on historical budget?
So the way that the TPR works is they start with the historical budget, then the different adjustments. But how it's done in rate setting is essentially on the rate setting system, and you're the hospital, and we agree it's going to be $100. It's all still based on rates. We agree. We think you're going to have 10 admissions. $10 for an admission. We think you'll have 10. That'll be $100. If the rate starts going up, what you can charge starts going down. If the rate of admission starts going down, what you can charge starts going up, and then in the end, it's $100. So that's basically they manipulate the rates to get the global budget by the end.
How about physicians from your alignment and that?
Sure.
They still make volume-based dollars, and when you start all incentivizing those hospitals to meet patients.
Yeah, no, I'm definitely going to get to some of the challenges. That's obviously one of the biggest issues. So we did get a great story in the New York Times, which was very helpful, and we talked about to CMS, now that we were in this incredible, difficult position with our waiver, well, let's build on what we started with the rural hospitals. where we actually had improvements in different health measures, improvements in other kinds of measures, happy hospital executives. And so we wanted to switch from a volume-driven model. We had a lot of volume in Maryland. You know, if you put a constraint on prices, you get a big push towards volume. And we switched to a population-based model where over 5 years, we would transition 80% of the revenue into global budgets. And we said that the per capita rate of growth for hospitals should be less than the smooth state GSP trend of 3.59%, that we would guarantee savings to Medicare against the national growth of $330 million over 5 years. There were many requirements for quality and patient experience improvements, and we were going to be looking at a whole range of public health indicators. And Professor Reinhardt called it the boldest proposal in the United States in the last half century to grab the problem of cost growth by the horns. I wish I had $1 for every time I built something. That's what he said. All right. So Maryland's goal was to move by the end of year 5, 80% of hospital payment to global budgets, like the TPR model, and by the end of the first 6 months, we were over 95%. So the hospitals sort of said, this is the way the world's working. We want to have our revenue, we want to transform for all of our patients. The basic hypothesis in Maryland was, you can have alternative revenue contracts, ACOs, et cetera, et cetera, et cetera, but it's 30% of your business, 40% of your business. How easy is it to have a culture change that says we hope to never see you again? But when it's 100% of your business, you better have that change if you're going to be successful. A whole range of things the state's working on, improving patient-centered care, reducing avoidable hospitalizations. There are multiple work groups that are going on. We have a fabulous health information exchange where the hospitals can tap into with all kinds of creative uses of data. Maryland, we have about 5.8 million people in Maryland, and we send the system sends out about 1 million real-time notifications about hospital ER visits to primary care, case managers, to behavioral health providers. There are dashboards every clinic has access to up-to-date real-time hospital utilization. People are, and everybody's planning together because they're in it together. People want to be able to hit their goals. And just a couple examples of what this, I realize this is a little bit off the beaten track from Spice-Variations. I will quickly go right back, but Meritus Health is out in Hagerstown. We had a little dispute when I was the health secretary between the health department in Washington County and the school system about who was going to run the school health program. It was turning into a bit of a political, problem, and the health system stepped forward. We'll take over a whole school health program, 22,000 students. I think it's close to 80 staff. We'll do it. And I called the CEO and said, why are you doing this? We never would have thought that the hospital would have taken over. He said, well, I'm one of the TPR hospitals, and we're looking at our data, and we have so many asthma visits for kids. We thought we could run the school health program at break even and make money on the back end under a global budget for asthma. And it makes you stop for a second and go like, interval asthma is. Why is it essentially we reward healthcare when there are more asthma ER visits? Why is it? But under a global budget, it's fundamentally different. I had at one point, not on here, but I had 5 CEOs show up in my office wanting to talk about mental health care and how to better help the chronically mentally ill. And I thought it was candid camera. What's going on? I got confused, they were confused, but but then I realized they're paid differently. They thought 50% of their treatment visitors to the ER had serious mental health disorders, and some of those hospitals, created partnerships with the Mental Health Association, others for urgent care, crisis response, and other types of services for the health department. Partnered with the community organization to do home visiting. Up in the right corner, St. Mary's Hospital, we created a program for health enterprise zones. The hospitals really jumped on it. One hospital put a health clinic in a senior center that had a ton of hospital visits. And another one created transportation routes, get people to primary care, major partnerships with WHCs. So you really see that, we'll get to all the problems, but I'm continually impressed by all the creative things that happen. And oftentimes when I'm in Maryland, I'm talking to groups of people, And I say something like, don't be surprised if you hear from hospitals. Don't be scared. Call them back. They're really interested in figuring out how they can do the preventable admissions. Someone will raise a hand in the audience and go, well, you know, school health, home health, nursing homes. There's a lot of engagement around improving outcomes and lowering costs. So in terms of the first year, which obviously there are multiple asterisks behind, we did get to certainly met the goal in terms of population-based revenue. We had all payer growth come in at 1.47%. We had 116 million out of the 330 million in savings. We a reduction in hospital-acquired conditions, and we decreased the national gap of readmission. So it was generally pretty positive. Maryland also gained the most rankings in United Health rankings, so a number of public health things trending in the right direction. Up in Washington County, I think they saw roughly 20% decline in ER visits and asthma on a population basis, looking at that population after they took over the school health program. So going back, I'll go back, now we're back to price variation. So I appreciate the digression for public health there. Rate setting meant the rates varied, but not because of market pressures. So you heard that pretty clearly. So there was less variation than elsewhere, which generally was considered good. This was from your commission year, just showing that that in general, the variation is far greater in Massachusetts than in Maryland across all these different diagnoses. Now that we're in global budgets, the price variation isn't so much of a focus at all, because if a rural hospital really would do prevent admissions, their rates are going to go up, right? If we, back to our $100 example, if it's only 5 admissions, you get $20. So, but you're only getting 5. So you're really starting to distance from the importance of price. So to the 3 questions, how to create a system that supports a healthier population, rewards high quality and efficient providers, and reduces healthcare spending over time. So, you know, my quick answer to that is everyone in the healthcare system should have aligned incentives for those goals. I think to the earlier point, one of the biggest challenges in Maryland has been trying to figure out the best way to align physicians with that. Maybe 50% of the way there for primary care doctors, because there's some very aggressive medical home models in the state. I think it's much more complicated situation for specialists, and there's a lot of that's been a big focus of the discussion with CMS on how to try to better align that. But I do think that's one of the biggest challenges. I think the 3 concepts here have to care about community health outcomes, not just quality. I was the health commissioner of the city of Baltimore, and I care about the infant mortality rate, the teen pregnancy rate, the preventable admission rate. I mean, it's great to take great care of people with heart attacks, but really you want fewer heart attacks. And for all the money we put in healthcare, that's not a primary consideration. Then it's a major loss opportunity. Second, I think without hospital engagement for value, there's little chance of success. I know that there's a lot of movement and pioneering efforts in Massachusetts in that area. But my last point is that it's really what you're going for is clinical transformation and doing things in an all-payer way where you have consistent clinical incentives for the hospital to demobilize for volume. I had a guy, very nice man, show up at my office. Won't tell you what hospital he's from. He's getting a distance. He said he wanted to evaluate. Well, you know, I think CMS. Well, I work in the finance, the office. For example, typically when we hire an assessment, like, how do I do this? Can we, you know, well, why are we doing that since we're in the global budget? What's the right assessment to do? It's like, go on, you know, like, we went through a few things, you know, we use this as an opportunity to reduce variation in the operating room, or, you know, why do people take so much longer to associate? We bring quality teams together, we improved outcomes, lower price. So you see, really, it's going to take some time, and there's a big culture change around it, but there are many opportunities when you can bring all players together. How do we ensure that different parts of the healthcare system are included? I think it's very important to have actionable data. I think that's one of the reasons Maryland has had a reasonably good start, is that we do have the health information exchange. I think that it may be possible to align under one budget, like an ECO, but I don't personally think that that's necessary. I think you can do alignment. So, global budgets are wide, but not vertical. They're horizontal, but they're not vertical. You're not pulling everyone into the same system. Now, we do have ACOs in Maryland, and you can do that. And the ACOs pay the hospital rates, and someone goes into the hospital. I don't think you necessarily have to think in terms of carving up the state into X number of ACOs, which is not that easy in Maryland. We have big physician groups that have been litigating against the hospital, or hospital-based groups, self-referral for a long time. They're not naturally the best of friends, but if you can figure out ways to align that, then everybody's kind of moving in the same direction. There's so much money in healthcare, everybody can wind up winning. And you have to plan, obviously, with all. The last point was, how can we accomplish a significant change while supporting opportunities to innovate and make decisions? And I guess what I would say is that in Maryland, even though we have this incredible amount of control over rates, I think one of the really key important things is that it's not micromanagement of hospitals. Hospitals actually, in some respects, probably feel much more flexibility with the global budget than they do having to deal with different payer. They get to decide how to transform, set their own strategy. There's a lot of flexible funding for them. And so global budgeting is an example of really local variation reform with rules set at the top, but a huge amount of flexibility for individual organizations. You visit one hospital system, Western Maryland, they have a clinic that will take care of anyone with diabetes, heart failure, asthma, nurse, nutritionist. They do that because they really saw the need. Someone else does something different. So but at the same time, obviously there's this element of control. I do think it's important for there to be a vision, and I think you all to them here are providing it. So from my perspective, place variation, I understand it's important, but I don't even think it's helpful. I think reducing price variation in the fee-for-service context doesn't necessarily either control expenditures or improve outcomes. But, and I would say, well, it may not be the short-term solution for you. It might be more of a solution for some of the smaller hospitals than rural hospitals than people might appreciate. I would just throw that out there. I would say a lot, but a number of other states are looking at rural pilots for global budgeting to really stabilize the situation. In that regard, there's a front page story in the Wall Street Journal that some rural hospitals are doing more hip and knee replacements with twice the mortality of the bigger hospitals. And I think of that as like the health policy equivalent of the operation was a success, but the patient died. Is it great? These failing hospitals need to basically figure out any way to increase volume in order to survive. It's not aligned with the health of their community. We should have a payment reform that actually reduces the disparity in health, life expectancy that exists. And global budgeting and other major reforms are creative ways to accomplish that.
Great presentation. Thank you so much. And since we have this expert here, I do want to open it up for questions or comments. I'll first start with my commissioners, but then please take advantage of this resource.
So just two questions on how does Maryland deal with that? Okay. One is, how do you deal with outpatient services provided in hospitals? We have a lot of people who go to a hospital for a one-off outpatient service. And second, how do you deal with physician-owned services vis-a-vis hospital services?
So for the first one, the hospital outpatient services, the hospital fees are part of the global budget. But none of the physician fees are part of the global budget. But anything that's a facility fee is part of the global budget. Before that was the case, there was a huge incentive for the hospitals to purchase, you know, or align with practices, move them onto the campus. I'm a pediatrician, say a normal pediatric visit is $70, pediatric visit plus facility fee, $70, you know. So that was a huge issue in the Medicaid. Now that that's no longer the case because the global budget, some of that is starting to, you know, come down.
Is there now an incentive to get the doctor to buy the imaging equipment so that it is outside of the hospital? We get paid for
Well, in Maryland, we have a law that prohibits physicians from owning or self-referring. So I don't know if that's a, so we have this, one of the strongest laws. That was one of the ones that's subject to a lot of litigation over the years. Usually there's a day in the Maryland General Assembly or something where they, you know, the specialties that want the equipment lobby to change the law. And let me just say that you have the radiologists against the specialists. There's testimony on both sides, but so I think that that issue isn't probably quite as.
So to that same degree, do you see growth of particular, it's like ambulatory surgical centers or things that are.
Well, what's tricky, I think, is that you want some of that to happen. Like the purpose is to have care at the right level. So I think one of the challenges, if you talk about what are the challenges to run a system like this, one of them is to know what is, you know, appropriate shifting and how to adjust the budgets. And, you know, a similar issue there is there may be some cases doing because they need the volume that really they shouldn't be doing. And it's better for them to come to academic centers, for example. So you've got to kind of get into that a little bit. So there's, I think, some level of moving cases to the right. That's important. The second major issue, technically, adjust the budgets, because it's not too hard to set up the first year's budget. But then when there's shifts in patients, how do you adjust the budgets? And the concepts there are basically, you don't get penalized if it's preventable admissions going down, as if there are market shifts happening. So those are the basic concepts. So if you know, then back when I was a medical student here who thought it was a good idea when it was patient was really needed to be, you know, kind of nudged out of the hospital to take all the salt out of their diet, you know. So I'm not sure that was a very successful thing to do, or possibly ethical, now that I think about it. But the in Maryland, it's if one hospital took all the salt out of the diet, the hospital, then that budget has to shift the next year, you know, based on the market share.
For academic medical studies, which are on Hopkins, Maryland, there might be others. Is there a sense of their feeling about the system of equity, about how they're treated relative to each other?
So you know, John Colmers, who is on the Health Services Cost Commission and used to run it, used to be the chair. He is very strong. He's really taught me a lot about this, and he and I negotiated this together with CMS. That this is a really important point. People have to have credibility in this. People have to have faith in the system that it's being done fairly. If that's not there, the whole thing falls apart. Sometimes he says, sort of like it rests on the consent of the government, because some say that. And so it is very important, you know, that even, and he would accuse himself when he's now at Hopkins, on specific Hopkins requests, but if the University of Maryland felt like this was a totally tilted system, that would be a big problem given their, you know, sway in the system. So it is, you know, run, it is, to the previous point, it is definitely an arm's length away from politics, but nothing is completely separate from politics. So it's got to be fair, and people have to perceive it as fair, and, you know, it really matters to have great staff.
Let me, truth is, I served for 6 years as a consultant to the Maryland hospitals on the internal battles within the hospitals. And it was very interesting because they have they don't have that very simplified adjustment where you just have AMCs and community. They have actual regression coefficients that measure teaching and stuff like that. And at one point, it got so that the rural hospitals felt really dingy, that the money was flowing too much. And there was an intense internal, this was not at the commission, this was within the hospitals, to find out what was the right amount of money to compensate them, because the rural and some of the smaller communities were feeling beat up. You'll relate to that well. So it came up with a recommendation. The commission itself didn't buy the whole thing. But as Josh pointed out, credibility was key. And even the teaching hospital said, okay, we'll back away a little bit. Obviously, they didn't want to lose all their money. So this idea of credibility was very real. I said before, if you're going to go down even something like this route, you have to listen to what was said. You have to look at the credibility of the system vis-a-vis all the institutions and all the powers, or you'll never get off the ground. Never.
So credibility is a defined part of data. Can you talk about how timely and complete your data was to make these kind of changes? What you did maybe similar to what we're doing?
Sure. So, there are two very current, strong data sets in Maryland. One of which is because they have to submit them every month and they get audited. So, very complete set of charges, ER and admission data, very accessible to the payment commission, and then there are public data sets that are put out at this level. We also have CRISP, which is the Health Information Exchange, which connects all the hospitals in Maryland, and it's also linked to hospitals in DC, Delaware, Philadelphia, and elsewhere. And those are real-time ADT notifications plus a clinical lookup. So every physician in Maryland can upload their list of patients to CRISP. While the patient is still filling in registration in the ER or a hospital, get a real-time notification that their patient is there. And then there's a dashboard they can get where they can look across all their patients at who's in the hospital, who's been in the hospital, and there are different other tools that are coming out. And just, one example would be is if a patient is discharged from hospital A, shows up in the ER at hospital B 2 days later, instantaneously, as soon as that ADT gets copied or registered, there's a match at both the discharging and admitting hospital are alerted that there's somebody who's come back so that they can make sure that their care is appropriate.
That's phenomenal, and I wish we could focus on getting that in place, because that would do a lot to bring everybody's cost of care down. We've been trying to do it for years, and we end up doing probably as well as anyone. It's very, very.
Well, it is important if you're thinking about the whole population. We just did a research letter in JAMA Internal Medicine where we looked at the Maryland data, and if you just ask hospitals individually for the names of people who were we didn't do this, but just as a hypothetical, for the names of people who were in the ER 6 times in the last year, you just got the individual lists from the hospital, you would identify, you'd miss 40% of the people in the state who did that because they're going to different hospitals. So, you really need to bring the data together to be able to identify the highest risk people and be able to.
So thanks for commenting on the health information exchange. I wanted to ask about this. I'm wondering about, I'm assuming there has resulted in decreased volume in hospitals, and I'm wondering what impacts you've seen on the healthcare workforce, not necessarily physicians, but nurses and other providers.
So obviously important question. I think, we had one of the things that was happening as the hospitals were getting squeezed before we switched over was that there were layoffs because the hospitals were under so much financial pressure, just like many hospitals around the country. I think that the goal for the hospitals is to shift workforce. So there are hospitals in Maryland that have dark wards. I've been to ERs where it's like, we thought we had twice the number of ER patients, and it's like a ghost, ER. It's like 50 beds, and they're all dark, But they moved the staff to other places. They've opened outpatient centers. They're doing different things. So I think like for example, there haven't been like workforce protests that, didn't come when I was there, but there were a lot of workforce transitions, I think. And having said that, it's never easy for a hospital to close. And so there are some hospitals that are kind of transitioning where there's different issues in Maryland, but I think, I don't think it's fair to look at this system and say that that's what's possible.
And those transitions, did they receive any extra training funding or anything like that, or did that have to come under the global budget at some point?
It pretty much came under the global budget, the hospitals figured it out. But, the ones I'm thinking of where they really did move staff over, it's, they are able to do certain things by attrition, offer people jobs, and then they really are hiring, in different places. And these particularly rural areas where they've been doing this for a longer period of time. Hospital is such an enormous healthcare program, and so they're, providing resources. A lot of people at those hospitals are really happy. They like to be able to, their job is to keep people out of the hospital. And they'll say things like, this is why I went to nursing school. It's like,
Any other questions or comments for Josh? Alan?
Could you speak a little bit about if you had just focused on the Medicaid population, what impact or challenges you might have found, because in Massachusetts we're getting ready to restructure our mass health delivery system, but the rest of the system is moving slowly towards a global budget. Could you talk a little bit about what you think would happen if you just focus on that one slice of population?
sure. I think that the concern is that it's hard to do clinical transformation patients. So you can create some capacity, for certain patients, but it's really hard to change the way you're thinking. It's hard to change their practice. It's hard to, radically think how to, do we even need to admit patients like this anymore? Are we changing our standard of care now that, for the right reasons? It's hard to really ask those questions and think them through if it's a relatively small percentage. So in Maryland, we've always been all payer. I'll tell you, just to your point, I would not infrequently get messages from the governor. I just met another governor and he told me something I was doing in Medicaid. How come we're not doing something in Medicaid? And I'm like, we're ahead of them. We're ahead of them, And he'd be like, I don't know, Josh. They're doing some great stuff in Medicaid in Oregon. And I was like, and should we build a Medicaid data warehouse? It's like we've got an all payer. We got everybody that includes Medicaid, and sometimes people go on and off of Medicaid. So I think that those of us in Maryland have kind of drunk the Kool-Aid for all payer.
Thank you. And I just want to thank you for this presentation. It's been very informative. And I have one question that, in hindsight, do you think there would have been value in bringing more providers into the system as opposed to just hospitals, rather than an incremental adding physicians, maybe nursing facilities, home health down the road?
Dealt with the deck of cards. We had dealt a hand. We had a rate setting system. The rate setting system, it was an opportunity that just presented itself. Every state has its own kind of opportunity, and I'm aware of the different ways other states have gone. All payer ACO discussions in Vermont, they're different things. It's sort of like, it's a kind of hypothetical that's hard to engage in. It's just so much of what our world was in this case. The one point I'll reiterate is that there's obviously a ideal where everybody is working together, like in a single organization. And I have a slight suspicion that that's going to be successful, that the energy people have in dividing up the dollar amongst themselves is really going to be that effective, because they bring so much to that. And that it may be, where that's possible, that's great. But you don't want to force people together and have people really resent each other. And, it may be better, you need everybody involved, but maybe it's not all under rate setting or all under one global budget, but maybe it's different ways to align. But, I think that might be the path through the woods.
Josh, one question for me. I'm interested in the position of the commercial payers and their employer accounts, and how do they view this system and work it with this system? What is their reaction to being part of this?
Sure. And our reform of this system, broad support, all the hospitals, the insurers, the doctors. Say the couple answers to that. One is the system itself has moderated private insurance rates because the public payers pay more than they do in other places. So that helps, and there's no cost shifting. So it's always going to say the same thing. So, if we were to lose rate setting, then there'd be a huge shift. So they like the fact that but they were also, I think, generally supportive of the idea of not having their own initiatives, like everybody's got some initiative, not be against a fee-for-service hospital system. Like you can have, like, I look at these evaluations of like medical homes and all these different pilots. It's like you're implementing that in an area where the hospitals, wings, I had CEOs say to me in the old system, I walked my office through the cafeteria, and if there weren't enough people in the cafeteria, I would start calling the ER, asking them how it's going. Do they know that it's, I mean, is it like if you've got the volume mindset going, these other types of initiatives to work. So I think that what the private insurers partly felt was, maybe it's not a perfect alignment, maybe we don't get it exactly the way we want, but as long as they're, they want us to succeed, we want them to succeed, that it is generally going to.
Thank you. All right, we have 10 minutes left here, and I guess I just want to kind of wrap up these 3 meetings, and again offer an opportunity for either my commissioners here or the different members of this group to offer their guidance or suggestions and feedbacks on what comes next. I think we all know, and part of what brought this group together was that there is a potential ballot initiative. There are ongoing discussions between the legislature and the administration, policy solutions, either that may be put in place in the next 90 days, or that may be part of a future legislative session. And the HPC staff and the board really want to support policy development that is based in evidence and based in data and based in this stakeholder consensus, and to have that buy-in, as the chair artfully said. So, to be determined what some next steps are. My next step is that we're going to be presenting to the full board at the next board meeting on a summary of these meetings, and I'll be asking for their guidance about how to move forward. But I'm also interested in your reactions on how best to move these conversations. I'm going to go around, so I'll start with Mike.
Thank you for convening these sessions. They have been a great initial step along the discussion curve, which I think needs to continue. I think what I would focus on for this group would be a set of principles that will be important to embrace no matter what happens on legislation or a ballot initiative. So prospect of an initiative or legislation, there will need to be a lot of detailed and hard work on the topic of variation. So as an example, if legislation passes or a ballot initiative passes, there's a lot of interpretive questions under those initiatives that require regulatory consideration. And if an initiative or legislation does not occur, rest on our laurels, and we should continue to have this dedicated discussion on a time-sensitive basis, this issue of acceptable and unacceptable variation. I think that this group has a lot of the players needed for that conversation, but I think there would need to be additional rigidity to the discussion were it to happen. And I can tell you that Blue Cross pledges to be part of that conversation, need to be part of it in terms of even adopting regulatory interpretations of whatever comes out. But I do think that this platform is a great running start for it, but it shouldn't end here. It should include more people.
I think I'd be remiss if I didn't sort of share what like GBIO congregants say. They say, at the end of the day, even though they appreciate, especially for the underpaid hospitals, sometimes their survival from an access perspective is important. all we do with price variation, so, move monies around, underpaid, but at the end of the day, consumers next year face a $3,000 deductible rather than $2,000, or $40 co-payments rather than 25, or insulin's going to $400 a month rather than 100. And sort of saying, what's this all doing for us? And I think there's appreciation that by some kind of, making it more fair and having value-based providers that make it might reduce the growth of overall spending. But I got to tell you, there's a lot of wonderment about where it's all going.
Went around, Steve. Sure. You don't want me to do it? Look, thank you again for a great series of discussions. I would say it's the flip, but it's the 25th, the 26th, and 27th discussion. So I don't know why there needs to be more discussions, candidly. Mike is clearly right that there will be some challenges in implementation of any plan that the legislature and the wisdom were to adopt. Folks in this room know that healthcare bills have passed in each and every session for the last 30 years. So the perfect is the enemy of the good, and we don't need to have the perfect plan to do something. And I think we sit around various tables and just say no all the time. Let's just say yes and try some things. If they don't work, we'll try something else. But I appreciate Mike saying this time is a concern, because I think it is, and I think it's a concern for our consumers in various parts of the state that are in need of healthcare services and are losing their hospitals. And nobody wants to see a hospital doing some things that they shouldn't be doing based on acuity or based on training. But we do want to see some hospitals that goes both ways. Some medical centers that are doing things that could be pushed back into the community. And that's a partnership that I think needs to occur and needs to be discussed. And I appreciate you lead the way in the various stakeholders that are here pledging to continue the effort. I just don't think it's an effort that can take too much more time, or I think we'll be left with a continuing declining base of community hospitals that are critical to the health of our families and our locals.
Thank you, Steve. I'm going to keep going around. Raise your hand. If you'd like to say anything, moving all the way to Laura.
I have to say, I think right now is a critical moment. We know the House, the Senate, the governor are talking right now with partners in SEIU on a ballot question, trying to come up with a solution. I don't know if the HPC is involved in that, if the AG is involved in that, if she is involved in it, but you guys have the data. We had 15 years of, we actually have 24 state reports that all said the same thing. We had a community report on community hospitals from 2002 that I guess Stuart actually shared, that warned about what our system could look like today. So Steve has lots of concerns about the future of community hospitals. I would want a special commission to many European experts remarkable and the Massachusetts. I'm sorry. Sorry.
John?
So, we have met 28 times, or 15, 20 reports, but we still have never agreed on what factors are acceptable for price variation. There was supposed to be a commission in chapter 224 that said, identify the acceptable factors and the unacceptable factors. I think we all, most people agree teaching is an acceptable factor, but nobody has ever said that values teaching factor variation, and then figure out what levels of variation is good for that. So I think that we need to do that, and I think the last HPC report, we looked at those 16 factors and said they are, I actually never said whether they were good or bad, but they were factors that they played into the variation. So I think before we go much further, we have to do that. I think this process has been helpful in that first session. I think it was pretty much consensus that some of the market-driven options of tiered networks and limited networks, didn't hold out much promise for reducing the variation, or actually had pretty adverse impacts on consumers at the end of the day. So I think that that was one area I think where we came to consensus, with the exception of, I think, the first Karen's presentation for the Attorney General's office. I'm not sure we'd be on that one, but a lot of those market-driven or product-based options really were kind of non-starters.
So I'm going to give my chairman the final word here.
Very quickly, because I agree with some of the stuff that's been said, but I do note that I was part of the drafting of the first cost driver report back in, when Martin Coakley did it. I'm still here all these years later, and it's getting worse. The only person that I feel sorrier for is Karen Tseng, who's actually drafted a lot of these things. It is getting worse. It's not just community hospitals, it's other hospitals. The strong are getting stronger, the weak are getting weaker, and we're still talking about what should we do. My friend over there, Steve, that we better do something, because if we do nothing, we're going to ultimately end up with an all-payer system like Maryland. The thing, I thought about moving there. I mean, it certainly sounds like a lot more sense than what we have here, which is entirely dysfunctional. But practically, it's not going to happen here, at least in the near term. But some things we have to change. At Boston City Hospital in 1974, we were charging Blue Cross Blue Shield $1,000 for a tongue compressor. We're still cost shifting. We've got to get to the heart of the dysfunctional marketplace. And the last comment I would make is, I think we spend too much time thinking about what are acceptable factors. In a market-driven economy, if we had a system of healthcare like every other industry in the United States, what are acceptable factors would be made by the payers, the people who are writing the contracts, the people who are negotiating the prices. I'm perfectly comfortable as a provider to give our plans the authority to decide when they negotiate contracts whether you should get more or you should get less. First question we have is, how wide is the corridor? I would submit to you, if they're getting 30 to 40% higher than somebody else, many institutions should, clearly. Academic teaching centers should be getting more than a smaller community hospital. If you got a large enough variation between the lower end and the upper end, and that's when I think we talk about compression, acceptable factors are already built into the negotiations that they have. And I think we leave that to them. What are acceptable factors for disproportionate variation is something that I think we're never going to define unless you want to spend the rest of our life doing legislation. If there's something that is above a mark or below a mark, then let the parties who made that decision come in and justify it. I don't think the government should be deciding whether it's an acceptable factor or not. I think we could build in procedures to have the parties to was above the line or below the line come in and describe why, because presumably they agreed on. Now, if they come in and one side says, well, it's market power, we can't negotiate, that kind of kills the conversation really quickly. It kind of gets you to the heart of the matter. Where if Blue Cross comes in and says, it's a burn center, I would point out we dealt with a burn center back 5 years ago, where it's this specialized service, where it's behavioral health, which I would point out, Leahy has third largest behavioral health organization in the state. And we're not holding it up as meaning we should get 1.5% above the average. Let the parties could justify it at that point. So I think I'm fearful that we're going to get hung up on trying to get too far into too much detail, but I think we actually can come up with ways to let the market work as long as we put a reasonable ban. And I don't know what that is, and I agree, that's a real interesting question. But once you figure out what the band is, I think you can deal with the rest of it. Thank you very much.
Thank you. Going back, I just want to remind people, one of the things that this state did to set the nation is when we decided to do health reform, we decided that we couldn't solve all the problems with health reform at the same. So it's really aimed at this issue. We decided coverage would come first and then cost containment. As the experts, quote unquote, argued we should do it all at one time. If we had tried to do it all at one time, we would have gotten nothing. So the question, the reason why I threw it out for discussion is that if we're focusing on price variation and the problems of our underpaid community hospitals, let's just deal with that. If we want to lower the amount of revenue we spend in the state, we need to deal with that too. But let's not, by combining them and the way we did here, inappropriately, you say 500 million to give 150 million back. You pay for it. That makes no sense, unless that's what you want to say. So that was why I threw it out. But as I said, every regulatory system that I've looked at for time separates them.
Except Stu, I understand the reason why you want them not connected to the same mechanism.
But I'm for
We gotta talk about both ends at the same time. I think that's what I'm trying to say.
And I think as Marcy said, I think there's, as you think about the entire system, there's ways that this could work together. So I think we'll leave that as the final point. We went a little bit over, I apologize for that. Thank you again to my HPC Advisory Council. Thank you, commissioners. Thank you for all the members of the public who attended. And look forward to seeing you at future HPC meetings. Thank you.